I welcome Dr. Sanjay Mittal, who is a senior consultant and a senior director of clinical cardiology at Medanta. He's going to be talking about decoding new heart failure signs. Where and how do I put dapagliflozin in treatment regimen? Dr. Sanjay, next 10 minutes for you.
Thank you, Dr. Khanna. I think without wasting time, I'll first go ahead with thanking the previous speakers for covering half of my topic of SGLT2 inhibitors. The importance here is that heart failure is definitely an increasing problem, and thanks to the interventional cardiologists, probably why the acute MIs are surviving and we are having a longer life. So not only the heart failure is increasing in prevalence all over the globe and India, but also if you look at the years of life with disability is also increasing substantially, and it's going to already predictably about 15% going to be higher by 2030. We have all the molecules, but SGLT2 inhibitors, before the SGLT2 inhibitors came, there was still a residual risk of about 20% in the patients who have heart failure with reduced ejection fraction over the period of the next 5 years. So that remains, and that is something which we actually want to highlight. Importance is the SGLT2 inhibitors we talk about. I'm talking about the dapagliflozin. And dapagliflozin, the famous trial, the DAPA-HF, actually was designed to randomize patients with heart failure, ejection fraction less than 40%, within the last 12 months, NT-proBNP should have been elevated, and EGFR above 30 to receive either dapagliflozin or placebo. And we know the results that the primary endpoints of CV death and heart failure worsening was reduced by whooping 26% in patients receiving dapagliflozin as compared to placebo. And the similar kind of results were seen for the secondary endpoint. If we look at the all-cause mortality, about 17% relative risk reduction with dapagliflozin, worsening heart failure by 30% risk reduction, and CV death with almost 18% reduction in events with dapagliflozin. And this was important that for the first time it was seen that even the non-diabetic people with heart failure with reduced ejection fraction behaved equally well as compared to the diabetics. And that is something which was important to understand, that 50% of these population was non-diabetic and they behaved equally well. The risk reduction of the primary endpoints was balanced between the two groups. The other important thing which came to light was there was 32% risk reduction of new onset diabetes by taking dapagliflozin. Obviously so, because it is a diabetic drug and probably reduces the blood sugar levels, but also probably by altering the heart failure dynamics is improving the adrenergic surge, and by the way of that, reducing the strain on the islets of Langerhans, and that's why probably leading to a decrease in diabetes incidence, but it is something which has to be watched for. The importance was, it has also been seen that the results show that the difference in mortality and morbidity of heart failure hospitalization rate was remarkable as early as 28 days of starting the therapy. That's why we are contemplating and all over the globe that we should start this therapy at the earliest. The other important thing was, if a person has been recently admitted within 1 year for the heart failure with reduced ejection fraction, the mortality and morbidity benefit was maximum. The primary endpoint reduction was as much as 36% if the person had a recent hospitalization for heart failure. Now, there has been a recent post hoc analysis of DAPA-HF trial, which shows that if you look at sudden cardiac death, this was remarkably reduced. If we look at the DAPA-HF trial, there were about 315 patients who had either sudden cardiac death, that was in 64% patients, or ventricular arrhythmia. This is complex ventricular arrhythmias, VTs, VFs, or torsade points or something. Or there was a resuscitated cardiac arrest, and these were about 315. And it was found that there was 21% relative risk reduction by addition of dapagliflozin as compared to the placebo. So this was another important thing, probably altering the heart failure dynamics. It is causing a reduction in certain cardiac death, or is there a direct mechanism which has not yet been explored? Quality of life indicators all showed substantial benefit. The Kansas City Cardiomyopathy Questionnaire showed that if you look at the total symptom score, it was more than 2.8 percentage point improved by addition of dapagliflozin as compared to placebo. And this was statistically highly significant. Even clinical summary score, this was 2.5 points better in dapagliflozin. And if you look at the overall summary score, it was 2.3 points better with addition of dapagliflozin. I want to also embark on the safety profile. The DAPA-HF trial showed that the drug was very, very safe. The apprehensions of hypotension, not there. Low risk of urinary tract infection, very low risk of urinary tract infection, even in non-diabetic populations. Low risk of renal events and hyperkalemia. These were all things which are bothering us as heart failure cardiologists when we are choosing a drug for heart failure. If you look at the gangrenes and urinary tract infections, it was hardly any difference between the dapagliflozin arm as compared to the placebo. And there was no hypoglycemia or DKA, diabetic ketoacidosis, in people who had no diabetes in this particular trial. If you look at the renal functions, there was initially a hitch that the dapagliflozin or SGLT2 inhibitors can worsen the renal function, but that is just transient. In the long run, dapagliflozin was much better as far as the placebo, as compared to placebo, by reducing the renal endpoints by as much as 29%. These were small number of people, so that's why the significance level was not there, but there was 29% reduction in renal endpoints. And if you look at the doubling of serum creatinine, also, it was much better in dapagliflozin arm. It was nearly to the tune of 44% risk reduction by addition of dapagliflozin, the chance of doubling of serum creatinine. So these were important things which were discussed. Now, there are certain changes in the guidelines. And what are these changes? The first change is that it was seen that if we have dapagliflozin, ACE inhibitors, or ARBs or beta blockers, we have nearly as much as 34% risk reduction of composite event as compared to those who are not receiving dapagliflozin. And this is in people who had recent heart failure hospitalization less than 5 months ago. And this is a comparative study that dapagliflozin and empagliflozin, both in combined form, showed almost a similar kind of benefit, but the mortality benefit was seen only by dapagliflozin, not by empagliflozin. And it was almost on the tune of the ARNIs. And this is on top of the ARNIs. On an average, there is about 8.3 years addition of years after 55 years of age of diagnosis of heart failure by addition of dapagliflozin, ARNIs on top of the conventional therapy as compared to the old ACE inhibitors and beta blockers therapies. So today, all the guidelines have included these 4 pillars. I gave you the latest 2021 European guidelines, which say these 4 drugs should be started at the earliest, probably within 4 weeks of the diagnosis of heart failure with reduced ejection fraction. Whether the person is stable or unstable doesn't matter. These drugs should be started, and thereafter they should be followed up for up-titrating these medications. And recently, just a month back, these updates from American College of Cardiology has been reported, where the expert consensus was that addition of SGLT2 inhibitor as a class is a treatment for patients with heart failure with reduced ejection fraction, and provides improvement in clinical outcomes in patients' reported outcomes measures. And this is why this has to be a class 1 indication for all people with reduced ejection fraction. Does not matter whether the person is stable or not, whether the doses of the rest of the drugs have been titrated to maximum tolerated dose or not. And the last thing which I would like to say, there's a huge bit of comments that we should start as step 1. And Dr. McMurray and Milton Packer, both of them opined that because beta blockers are the only drugs which reduce acute cardiovascular mortality by reducing sudden cardiac death and ventricular arrhythmias, they should be the first drugs to be started in heart failure with reduced ejection fraction. And SGLT2 inhibitors actually negate some of the side effects of beta blockers of worsening heart failure by causing diuresis and all. So they can be a common adjoining of these drugs. Single dose, 10 milligrams once a day, and very well tolerated, they should be considered as the first line treatment. Next, I would like to end my talk here that in a heart failure situation with reduced ejection fraction, a lot of points are there to be discussed. Point number one, whether the heart rate is less than 60 or above 70 with sinus rhythm. So a lot of things have been there. There could be a hypotensive person or hypertensive person or a normotensive person. The kidney disease, which is so very frequently identified in patients with heart failure with reduced ejection fraction, is a major bottleneck for many of the things, especially the ACE inhibitors, ARBs, ARNIs, and MRAs, and even the diuretics for that matter. Hyperkalemia. Atrial fibrillation or no atrial fibrillation, ivabradine would be out. Beta blockers also have a dubious role to play in people with heart failure with reduced ejection fraction having atrial fibrillation. And the rate control in atrial fibrillation is also not very classically employed. So in situations like this, dapagliflozin seems to be having a niche in the sense that any kind of glycemic status, heart failure, ejection fraction, any ejection fraction, baseline mortality risk, heart failure etiology, nothing of them, you can straight away start dapagliflozin. The only concern is that you have to advise the patient to observe the genital health carefully and be watchful on the intake of certain other medications. So any kind of the things which I have mentioned about dapagliflozin can safely, or SGLT2 inhibitors can safely be added in any kind of heart failure scenario. So, ladies and gentlemen, dapagliflozin is a drug which can be used across the board in any kind of heart failure with reduced ejection fraction. The guideline-directed medical therapy is inclusive of SGLT2 inhibitors, and a simple dose of 10 milligrams once a day is substantial enough. But be cautious that there could be three situations when we have to be cautious about SGLT2 inhibitors. EGFR should be more than 30. That is what the recommendation is. The use of background cardiovascular drugs and diabetic medications, especially the diabetic medications, be watchful. The person can have hypoglycemia, so reduction of sulfonylureas or insulin dose, almost 10% when we are adding SGLT2 inhibitors recommended. And the other background heart failure therapy, specifically being a diuretic, we have to down escalate the doses of loop diuretics in these patients and watch for possible hypotension, although the hypotension reported with these drugs are minimal, but that has to be watched for. Thank you. Thank you for your attention.
Thank you, Dr. Sanjay Mittal. Because the paucity of the time, I request Dr. Nandakumar to make final comments, and also one question may be allowed. Dr. Nandakumar, please.
We had two excellent talks today. One both about the guideline-directed management. To Dr. Samir, are you uncomfortable at a certain level of LDL, or is it okay even if it goes below 55 to say 40, 35 LDL? Sometimes we do see, because as we all know, in Indians, the response to statins is sometimes overwhelming. I mean, unlike our Western counterparts, many of them do not need 80 or 40 to achieve a LDL of 55 or lower. So are you comfortable with LDL lower than that, or do you consider de-escalating from 80 to 40, if not to 10 or 5?
So that's an excellent question, and I believe, Nandakumar, that if your patient is in the category of a high risk, which is the kind of patient which we were discussing, already has had an event, I believe less than 55 definitely. But if it is extreme risk, the Lipid Association of India now classifies a new category, which is extreme risk and very extreme risk. And in them, you can go even up to 30 in certain situations. And I believe in our part of the planet, we must be very, very aggressive. We have young people, we have epidemic of diabetes, hypertension, when we were doing our training, hardly we used to see these kind of lesions, the kind which we are seeing nowadays, and especially in winters and with pollution. So there are certain non-conventional factors, and statins at a lower level have shown benefit. Yes, something around 20-25 milligram per deciliter of LDL, I would be concerned. In the PCSK9 trial, although they say that even up to 10 was okay, but still we need to see there are certain caveats. But yes, around 30-35 in extreme risk, I would be comfortable.
Dr. Sameer, can I ask you a question? Statins, you showed very beautiful data, is responsible for plaque reversal. My question is it due to LDL reduction or inclusive of LDL reduction? We are talking about the LDL targets and all, but there are a lot of other effects of statins also. And that is one of the reasons why we should not reduce the doses of statins targeting to just LDL. In my opinion, what is your opinion about it? Is it due to...
Absolutely. I'm absolutely in sync with what you are saying, Dr. Mittal, that unless and until there is a gross indication like the patient is not tolerating or develops a serious side effect, we must not try to de-escalate them unless we reach a level, say around 20-25, where I would be skeptical. See, with high risk, and the only issue is they at times raise the lipoprotein A levels, and then probably PCSK9 inhibitors may come into picture there, but again, because of their cost. But one thing is clear for me, these are drugs which have stood the test of time. And if you are achieving even an LDL around 30 in a very high risk individual, we must try to achieve that. Ezetimibe is something which we must try to use wherever possible in addition to statins to achieve the goal.
Thank you, Dr. Sameer, Sanjay, and Dr. Nandakumar, Dr. Rajshekhar. You had an excellent session, and watch this time. We'll move on to the next scientific program session. Over to Dr. Khanna.